Hello, everyone. I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance. Thank you for joining us. October is National Pharmacist Month, which is a great opportunity for us to learn about the role of pharmacists in community oncology. Our guests today are Judy Alberto, a pharmacist and the Director of Clinical Initiatives for COA, and Jonas Congeli, pharmacist and Chief Strategy Officer for Hematology Oncology Associates of Central New York. When we think about pharmacists, the image that most likely comes to mind for most of us is a pharmacist working in a retail setting, places like Walgreens, CVS, or whatever your local drugstore might be. But there are many different career paths for pharmacists. And today, Judy and Jonas are going to share their insight about each of their non-retail pharmacist roles. Like their retail colleagues, they're responsible for medication oversight, but when working in an oncology setting, they do that role, but they also do many additional roles using all of their skill sets. And the fact that pharmacists are a part of community oncology is very beneficial to patients as well as to their doctors. Welcome, Judy and Jonas. We're going to get started. So, Jonas, I want to start with you. As I mentioned to our audience, you work in a community oncology practice, and I want you to describe what the role is as a pharmacist working in a community oncology practice.
Thanks, Rose. Happy to be here today and able to talk with everybody today. I've been a pharmacist since 1989. Is when I graduated, and have been involved in oncology almost my entire career in there. And I've always, just always very interested in oncology. It was just something that, there's definitely a challenge to oncology. And when I first started, there really wasn't a lot of pharmacists that were involved in oncology. I was just very fortunate to be part of when we saw oncology really moving from the hospital systems to outpatient. And unfortunately, what we've seen over the last 10 years, we've kind of seen it kind of going in the opposite direction in there, where we're seeing a lot of the hospital systems, taking up more and more oncology practices. But I've been with HOA CNY for a little over 26 years. I'll be going on my 27th year, which has been great. And started really, I was the first pharmacist for the practice. I think back then, for a community oncology setting, they weren't really quite sure what to do with the pharmacist. But I think the practice had grown to a certain size, and we're realizing that, a pharmacist could provide a lot of services that were being done by maybe typical, nursing staff. And I know that there's a lot of, nurses that still will mix chemotherapy and all of that. But I think there's a certain size where it makes sense to have a pharmacist and a pharmacist-led team involved in the pharmacy operations in there. Nurses are fantastic, and I love our oncology nurses, but they really need to be focusing on taking care of the patients and not having to worry about, mixing and, drug calculations and all of those other things. That's where, we can kind of come in and help them. So, initially when I started, it was really around that. It was really providing, adding another layer of safety. We're dealing with highly hazardous drugs. And we need to make sure that they're being delivered safely. And then also to add some efficiency as well. So our primary focus, or my primary focus when I first started, was on safety, making sure that, things were being done, that there was another layer of safety there. And then the second thing was to make things more efficient, right? So to create some of those standards that weren't really existing before inside of the practice. And then, my role has just changed over those years, becoming more involved in the purchasing, the contracting, and to overseeing when we started doing dispensing. So, traditionally the role of pharmacists in the community oncology practice was more infusion based. Now it's definitely, we're seeing more of an oral focused role in there. So it was exciting building those dispensing operations within the practice and seeing those grow and being very much an integral part of what we do. in here. And then, to now where, we have a whole team here at HOA. We have 5 pharmacists, almost 10 technicians in there. And it's just to be able to provide that level of service that needs to be done.
Jonas, that's very impressive. One of my questions I was going to ask, and it's like you read my mind, was you mentioned the word team. You start off as a sole pharmacist and now you have a team. And you also mentioned that in the early years, not a lot of community oncologists had pharmacists. And what I've learned, traveling across the US, going to cancer centers, doing CPAN work, I also was learning about pharmacists in the community oncology setting for the first time. So for those practices that don't have a pharmacist on site, what is the reason for that? And then Judy, we're going to come over to you in just a minute.
Yeah, I think there's, you hear a lot of things like, oh, we're too expensive. I think that's probably the most common, or sometimes they're just used to doing things that they've always done, right? And so they don't really know or understand the value that a pharmacist can bring to their operations in there. So I think those are the thing is the lack of knowledge and understanding of what a pharmacist can do. And then there's also that, we're too expensive, to bring on. So those are the 2 things. And then there's also, I think the third is I've kind of said is, well, this is the way we've always done it, right? We've always had the nurses mixing. We've always done it, in this manner. So they don't necessarily think, or look outside of that. But I think that's changed a lot. I know that's changed a lot. I think almost every practice that I would say large size practice has a pharmacist, many pharmacists actually, on staff. So I think it's definitely changed and grown over the years.
Well, thank you. And I think the one thing all of us should write down is you said pharmacists add another level of safety. And I think that says so much. Thank you, Jonas. Judy, you now work for COA. You're my COA colleague, and you're the Director of Clinical Initiatives. This is a brand new role for COA. Can you tell us how your work as a pharmacist is guiding your work now as the Director of Clinical Initiatives?
Yes, and thank you, Rose. Thank you for having us on here. And Jonas, agree with everything you said. Pharmacists are such an integral part of the team. I was also a pharmacist in 1989. That's when I started. I joined Oncology team about 14 years now, and absolutely love it. Just fell in love with oncology. So my role at COA, it is a new position. I'm really excited to be here and really supporting everything that COA does and to improve clinical care. My role is to be that liaisons and really to bridge that gap, that clinical gap. COA is so strong in oncology and all of the legislative issues that they do that my job is to support that ongoing effort and really focusing on advancing our clinical side and bringing those 2 together. So really looking at the practices, identifying the needs, looking at pharmacists, pharmacy technicians, and seeing how we can better support them to improve the overall patient outcomes, decrease costs to our healthcare system, and really make improvements and keeping the patients at the forefront of what we do. And so now I also lead our COPA, which is our Community Oncology Pharmacist Association. And so really bringing that into the future with value and clinical initiatives, and being that person that finds out, what are the gaps, what do we need, and then connecting those gaps and supporting our practices. That means our pharmacists, our pharmacy technicians, our physicians, and overall, and like you said, that medication management, really looking at how can we improve that, how can we make that more safe for our patients and their cancer journey.
Thank you, Judy. You mentioned COPA, which is a Community Oncology Alliance Pharmacy Association, which of course by the word pharmacist, it means it's for pharmacists. So how can pharmacists get involved with COPA, and who qualifies to get involved with this subset of COA?
Yes, great question, Rose. And so you can register right through My COA. And when you register on the COA website, there'll be an option to choose COPA. And then you'll be signed up for, we have a listserv, we have monthly membership meetings. I'm always looking for people who are doing great things that we can have some presentation, like 15, 20 minutes during our meetings that you can present what you're doing, how the pharmacists are making an impact. And it isn't just for pharmacists. And so pharmacy technicians, we have physicians that join, we have nurses, we have APPs. So really any administrators, anybody in the practice would benefit from these meetings and the listserv that we have and all the ongoing education that we offer.
That's great. That's very good. Now, when I opened up with my comments, I said that when we think about pharmacists, it's very natural that the majority of the general public is going to think of Walgreens or any kind of retail location. But Judy, when you also mentioned, our COA's work with legislative and policy issues, it made me think of something that's always in the media, and this has to do with mail order pharmacy. So certainly pharmacists know what this means. What does the whole mail order subject mean to patients? And can you both give me your insights on this topic and for our audience as well?
Yes, absolutely. And I think when you hear mail order, patients think that that's a great thing. And certainly you get your medications delivered right to your doorstep. Sometimes it's an auto renew, and that could be very convenient for patients. But what we don't always think about is that face-to-face human interaction with the pharmacist that you get from your community setting. And that is so critical to Jonas, what you were saying about really adding that layer of safety, that patient safety to what we do. And you don't get that in that mail order. And we know with cancer, oral cancer treatments, it's about 40% now that it's increasing, going from injection now to orals. And so it's more important than ever that the pharmacist is part of that team, is part of that face-to-face interaction with the patients and adding that layer of safety. So we want the patients to come into the community setting. We want to talk to them. We want to counsel them and educate them. We want to be that face that they ask us questions and help with all of their support needs. So while it sounds like it's a great thing, when you're dealing with cancer and oral medication, we prefer our patients to be, seeing us face to face and letting us assist them. And Jonas, what are your thoughts on that?
Yeah, no, I agree with what you said there, Judy. When I look at the mail order pharmacy, I think mail order pharmacies do a great job servicing patients that are on chronic medications for things like cholesterol or blood pressure or things that don't really need, that aren't really going to change frequently in there. As Judy said, I mean, orals are becoming, a large part of what we do. And now what we're seeing is not just orals being given individually, they're also combined with IV therapies. So the level of complexity just increases more and more. And it's vital that you keep patients on their therapies the way that they're intended to be. So if an IV therapy is to be given on day 1 every 21 days, and that oral therapy has to be given on, day 1 through 14 of that cycle, it's very important that we're able to make sure that the patient has that medication and is taking it the way that it's intended to be. And what we see is with mail order pharmacies, oftentimes is that we're forced to have to use them for certain patients. And we see this fragmentation of care where all of a sudden, yeah, we do a great job making sure that the patient's IV therapy is being given and delivered when it's supposed to. The problem is that now that the oral therapy may not line up with the way that the IV therapy is supposed to be managed on there. The other thing too with, retail and mail order pharmacy is that, and as especially when you practice like we do inside of a community oncology practice, is you have access to everything that you need. I mean, first and foremost, you have access to the patient, direct access to the patient. You have direct access to the patient's physician and their care team. You have, direct access to the EMR. So you see all of the records that are in there. You have access to their pathology, their labs, everything that you need to know to be able to make an informed decision on when you're managing patients on oral and IV therapies. When you contrast that to what a retail pharmacist or a mail order pharmacist, I mean, all they really have is the name of the patient, the medication that was prescribed. They may have a little bit of a medication history, but that's about it. And so when you look at it and you see, well, they're dispensing these highly toxic, can be very complex, medications, the regimens and such, and you see what's happening and going, geez, is that really the best way we should be taking care of patients? And when you take a step back and you can look at it objectively, You say, no, it really isn't. And I'm hoping that we can take what we're seeing here in community oncology, and that maybe we can start seeing a paradigm shift, because pharmacists should really be embedded in almost, every specialty, and even family care and all of those as well, because when you're closer to the patient, the better the care is going to be.
Jonas, I can't even imagine dispensing an oral medication like that and not having access to the patient's electronic health records and not seeing, was there a phone call made previously that the patient called in with side effects? Like you said, is there something else that may work better? So having that immediate access to the team, to the records is really, again, adding that another layer of patient safety in this area.
Absolutely. And what's funny is that we have these mail order pharmacies reach out to us when they have questions, because, they don't have, they don't have anything. And so oftentimes they're reaching out to us, and we're the ones that are, answering the questions or managing the patient's therapy, for them. And, and again, it's not all about reimbursement, but at the same time, they're the ones that are receiving the reimbursement while we're doing all of the work. It's not a fair system in there. When you look at it from that perspective.
Yeah, for sure.
Really good overview from both of you. Judy, you mentioned the positives of mail order pharmacy, that patients will think, well, this is easy. I don't have to go drive. It comes straight to my doorstep. And then, of course, both of you have explained what the negatives are. You don't have that pharmacist contact, and patients always want to be comforted. But Jonas, I want to go back to a few years ago. We happened to have a CPAN chapter at your practice. And I know that one of your local political leaders came to the office, and a big part of it was about drug waste. Drug waste. And we had one of our CPAN advocates, who was a cancer survivor, had taken photos of medications that were left on her doorstep. And Judy said auto refill, but she was no longer on those medications. I don't know if you recall that story, but if you do, if you want to talk a little bit about also the waste, and then also if you think it's great to go get your medication out of the mailbox, but isn't it true that some medications should be refrigerated and not in a mailbox? Can you both talk about that?
Yeah, for sure. And I do remember that. And it was great. And we do these, it's called a sit in my chair event, right? And we've talked about that. I know you've talked about that previously in there. So we bring in a lot of people. We bring in, representatives, senators, local, regional politicians, employers, and everything. And one of the things that we try to show them is the amount of waste that occurs in the mail order system, because again, they don't really, there's nothing for them to really look at. All they're doing is going, okay, the patient needs the medication this day. So about 7 days before they ship it out to make sure that the patient has it in hand for when they need it. The problem is that there's a lot of things that are going to happen between those 7 days from the time they send it to when the patient is going to take it. So I do. It's one of the things we show and demonstrate. We have a bag. It's about the size of a grocery bag, and it's filled with unopened, medication bottles that nobody is going to take, because patients bring it in because they don't want it in their house. So we bring it in, and for years and years and years, we would just dispose of it appropriately for them. We have all of the mechanisms to safely dispose of hazardous drugs. But then we were thinking, well, geez, this would be a great demonstration to those that may be interested in this, to show them what is really occurring in the system. So we have it in a bag, and we slowly lift it out of the bag, and then we have the price on it, what it is. And it's just amazing, keeps growing and growing. I think right now it's probably a little over $400,000 of medication. Again, this is unsolicited. This is patients bringing in. I could only imagine if we reached out to our patients and said, please bring in any of your, chemotherapy medications that are sitting in your home. We would probably be overwhelmed with it. But it's just amazing, just that little sampling that occurs in there of waste that is being generated by the mail order system, that I don't think is really being necessarily tracked or reported in any sort of meaningful, manner. I mean, you can look at some studies. They say anywhere from 20 to 50% of medication through a mail order system is wasted. And so you kind of start thinking, well, geez, what is this overall cost to the healthcare system when it's being like that? So we don't dispense anything in the practice unless the patient is going to take it, and we make sure that the dose is the right dose in the right schedule that they're going to be taking on there. So what we do is
how often is that changed, Jonas? How often are those? Do you see that those doses change due to side effects and toxicities or progression? And if you weren't on top of that, if you were just automatically sending it out, I mean, it's crazy. I can't even imagine what the patient is getting. And then, like you said, it's sitting in their home. It's hazardous to anybody else who may touch it. And so you have a problem. And when you're in the setting you are now, you can stay on top of that and you can monitor and manage that and really mitigate that wastage.
I'm hoping to have an answer to that soon, Judy. One of our performance improvement projects for this year is to look at that. What is that cost avoidance? By us actively managing patients, what does that look like? So we've just started measuring that. And so just from the second quarter of this year, I have data from that. It was close to $600,000 in cost avoidance that we've been able to manage. And these are just like you're saying, dose adjustments, discontinuations, modifications, all of these types of things that go into there. So we're hoping that maybe we'll be able to get a poster or maybe a paper out of it just to document really what it is, that we're doing by intervening.
And then to your point with the chain of custody. And so what that means is when you send that prescription out to your patient, if it does need to be refrigerated, or sometimes it needs to avoid heat. And so if you're in the middle of the summer and your temperatures, I'm in Texas right now, we've seen up to 115 degrees. And so if you have a prescription sitting in your mailbox and you have those type of extreme temperatures, that's going to be a problem. And so by keeping that chain of custody between the pharmacy and then directly to the patient and telling them to avoid that verbally makes a big difference than something that's mailed to them and now sitting in their mailbox for who knows how long. They may not even know it's there. I know I don't check my mail every day. And so maybe 3 days later, that medication may not be effective any longer. So it's a big concern.
I'm so glad that, you're both here to educate us today. And again, getting back to like not all community oncology practices that have a pharmacy setting, but I know, going back in time when I was going, to all these, to all our community oncology practices, I would always get a tour of the facility. And I was so impressed with the whole pharmacy section because I wish almost all patients could see it because it's always behind the scenes, but such a sterile environment, all the cooling chambers and all the guidelines for everything. It's really, I just remember thinking like how wonderful for patients to know that everything is so protected in this way. I want to go on to another question. So cancer patients or any kind of patient, we all know there's a lot of guidelines online about how to prepare for your doctor's visit, because as we all know, not just in oncology, but in any other basically profession, specialty, is most physicians only have maybe 10 minutes with patients. I know that sounds really shocking, but sometimes it's a really short amount of time. So patients are told, think about your questions, before you go in. Do you have guidance on that for what patients should talk to their pharmacist about, or before they just go pick something up? Do you have any guidance on that? Does that even apply for pharmacists?
Yes, that's a great question. And to your first point about seeing your pharmacist, patients love to see their pharmacist. And they've seen this time and time again, whether it's your oral therapy or like Jonas was talking about, if you have an infusion center, that can be scary. And patients love to see and talk with their pharmacist who is going to be preparing and checking and overseeing their medication. So yes, a pharmacist on the healthcare team, you want the patient to focus on all things medication, side effects, support therapy, and bring those questions to your pharmacist. And they can actually be used as a physician extender and be that intermediary between the physician and the patient. I mean, literally, you can bring those questions and get free access to medical advice while you're waiting to see the physician, or you can't get an appointment, you can call your pharmacist. And so we really want everybody on the team to be working to the top of their license. It also takes the burden off the healthcare team and prevents that burnout because everybody is doing what they were highly trained to do. So yes, absolutely, their patients should bring those questions right to your pharmacist.
Yeah, and to that point, Rose, I think we anticipate a lot of those questions ahead of time. I mean, it's important to bring those questions you want to ask the physician because it can be definitely different depending on, you know, the situation or what you're going to see them. I think when we're talking about you know, drugs, it's a little bit more specific. So we kind of already anticipate, you know, what it is, and then even more important, we anticipate and we plan on what are we going to ask you as well that you may not even have thought of, you know. So there's a lot of things because it's not just a one-time visit with us, right? It's that initial visit, that appointment that we have, and we sit down, we go over the medication, we do a really good job with the teach, and then we follow up with the patient anywhere from 3 to 5 days afterwards. And then again, we're following up and asking them these questions. You know, do you have anything? You know, how are you taking the drug? How are you? You know, are you experiencing anything? Do you have any further questions? You know, all of those things. And then we're reaching out again, and depending on from that conversation, we may set up another appointment, you know, just to kind of touch base with them again. But we are always, you know, reaching out to the patients before their next appointment coming in. What we try to do is here in our practice is we try to align those activities with when their next dispense is. So if they're going to see the physician or the nurse practitioner or PA, is it maybe just a lab only appointment? Are they seeing, you know, the physical therapist or the nutritionist or whomever it is? We try to line that up so that they come in there so that we do. But most importantly, we really try to line it up with the physician as much as we can in there so that appointment is very seamless and things don't get off track in there. And especially when scans are coming up, it's very important that the scans are going to align when that next cycle is going to be about a week before that, so that, you know, so it's important. And we probably take it a little bit further in our practice where we're actually actively managing the patients, the regimen, the cycles, the scheduling, the appointments, and all of that. Again, because it's very important to make sure that everything is in alignment.
Yeah. And you see it from that perspective, you know, what a physician looks at it a certain perspective, nursing does their checks, and pharmacy, very important to look at that with that perspective of medication therapy management. That's great, Jonas.
Yeah.
This has been so interesting. Go ahead, Jonas.
Yeah. I think with, you know, what we try to do is with the orals, and I know we kind of focus a little bit more on orals here, is we really want the oral regimens to be treated in the same way that we treat our infused regimens, right?
Exactly.
There's no question when you look at that, right? They see the physician usually the day before, 2 days before, so that everything is in place, so that the next day when they come in for their infusion, everything is done. The dose modifications change, or if the therapy is going to be, you know, held and moved a week, everything happens. So we try to make sure our oral therapies are in alignment in the same way, so that they're coming in and all of that. So that's really what our goal is here, is that there is no difference whether you're on oral therapies or IV therapies. You're being managed in the same way.
And that's a great point, Jonas, because when you do come in for your IV therapy, it's actually a little bit easier because your patient's sitting in a chair, they're getting the dose, you know, they've gotten that whole dose, you can monitor them while they're there to see how they're doing, but you don't have that same benefit for oral. So to make that oral environment just like the IV environment is really important, and sounds like you're doing such a great job. And for the patient benefit is enormous to kind of have those two worlds meet. So that's great.
These advocacy chats are designed to provide education. You both are certainly doing it. I want to ask our audience, if you have any questions, we have a few more minutes left. You can put it in the chat box. And while we're waiting, I want to ask also, I want Judy and Jonas, is there anything that you really feel I haven't asked and would be very beneficial for patients to know that we haven't covered? We talked about national policy issues.
How much time do you got, Rose?
I know, right?
Okay, we have to make it succinct. Focus on succinct.
I
think we did a great job covering, that. I mean, we could go on and on. There's just so much more to cover. And I know the questions we prepared ahead of time that we didn't even get to because, the time really ran here. But there is so much. And I think, CPAN, I think, is doing a great job from an advocacy perspective. Certainly, we love, we have a chapter here, as you know, it's very active. And we love going down and trying to advocate for our patients. Our patients come down and advocate for themselves. So it's, I think what you guys do is very good.
The only thing that I would add, I think we covered so much, but Rose, you started off saying that, and Jonas, that sometimes some practices don't have pharmacists, and maybe that barrier is financial. But what I would leave with is to say, for a small financial cost, you can really decrease cost overall for your practice. You can improve outcomes, and you can make a patient safer, and the whole process more smooth. And so, we would like to really promote pharmacists in practice.
Yeah, well, I agree. And I hope that all of us can, thank a pharmacist, not just this month, but all the time. And just a quick little personal note, I had to actually go to a retail pharmacy recently, and just seeing like all the medications, I thought, oh my God, the responsibility that pharmacists have must be nerve wracking. Even with myself, just taking my own medication, like, is this right? Should I, it's such an important job. So thank you so much for your time, and you're doing great work. And if we can go to one last slide. So thank you, Jonas and Judy, and of course, all our listeners. Next month is Pancreatic Cancer Month. And though COA is not a disease-specific organization, pancreatic cancer is such an important cancer to learn about, because all cancers are very scary and terrifying. But I think it's pretty universal that pancreatic cancer is a cancer that puts fear into everyone. So hopefully we're all going to learn a lot and leave this advocacy chat educated. Our guest for next month is going to be Cindy Gavin, who is the founding executive director of Let's Win Pancreatic Cancer. So thank you, everyone, and enjoy the rest of your day.